So very good evening everyone. Good evening everyone. Hope all of you are doing good. Let me know in the chat box. Give me a thumbs up if I am audible and visible. A very good evening everyone. So today in this session, in this short quick session, we are going to discuss some of the recalls questions of psychiatry of the yesterday's INI-CET exam. Right. So again, before starting, again this is just a disclaimer that these are all recall based questions, and we'll try to put the as close as possible to the questions which were asked yesterday in the app later. Now, so I've seen the questions which were sent by the students, and I'm sure you must have also analyzed, and some of us might have over analyzed yesterday's question. And I would agree this time, yes, psychiatry questions were a bit on the tougher side this time, but this is what INI-CET is known about. So yes, this time psychiatry questions we'll discuss were a bit tricky, and we'll try to solve those questions, and also we'll take this opportunity of this session because many times we see that the topics they get again repeated in the upcoming exam. So we'll take this opportunity to discuss some of the important points which may also be relevant for the upcoming NEET PG as well as for the FMG exam. Again, some of the questions which I'm going to discuss, many of those questions you will find they were from the PrepLadder videos in the app and also from the notes, and also some of the questions directly indirectly from the LRR session which we did, and also previous year topics, as in we are again and again discussing that previous year topics are very important. Now we could gather nearly 9 questions of psychiatry along with some of the other subjects as well. So I'll try to discuss those questions also, which seems to be integrated. But if you had good knowledge of psychiatry, some of the questions were also being solved. So very good evening. Right. So let us jump to the first question. Let's see this question again. This topic we have been discussing again and again. And again, this question has come on rapid cycling. So the question is, rapid cycling is characterized by all of the following except. So they have asked except. So let's see this question. In fact, even in January this year, a question on rapid cycling was asked in the FMG exam. So again, for the upcoming NEET PG, again, this becomes very important. So the options are at least 4 distinct episodes per year. This we definitely know is true. So we have to tell the false statement. So let us see. Can you answer what is the, what is the answer? I hope these are the options. Let me know if there is any change in the question or in any of these options. We'll try to rectify and try to get as close as possible to the exam question. So I hope this was the question most likely. Right. So the options are antidepressants increase the likelihood. Again, we have talked about this, that in bipolar disorder, sometimes in bipolar depression, when we have to give antidepressant, we add a mood stabilizer, because antidepressants, they may lead to a switch to mania or hypomania. Very good. So also hypothyroidism is also one important condition which is related with rapid cycling. Yes. So the false statement is that it occurs more commonly in male. This is a false statement. So the answer is, in fact, if you see the videos, this point I've discussed in the PrepLadder main videos. We have talked about this, that rapid cycling is more common in females. So again, if you know, I've been discussing in INI-CET a lot of such questions on epidemiology. Somewhere they'll try to fit in such questions. So this time it was on rapid cycling. We know rapid cycling is more common in female. So let's discuss some points about rapid cycling, since this topic has been asked recently in many exams. Okay, very good. So the answer here is, I hope it is clear to everyone. The answer is, it is more common in female. So the incorrect option is D. So let us discuss briefly about rapid cycling. And I'm expecting, again, since they're asking rapid cycling questions, so please, when you're revising for NEET PG FMG, read it again. So rapid cycling, bipolar disorder, we say when there are 4 or more episodes of depression, mania, hypomania in 1 year. Rapidly, the symptoms are going up and down. So rapid cycling. So as you can appreciate here, 4 episodes have occurred in 1 year. This is rapid cycling. So let me discuss certain factors. So let's make this list, so that we know all the important factors which are favoring rapid cycling. So let's make this list. Let's try to remember some of the important points. So first we have discussed female. Yes, it is more common in females. Also see, borderline hypothyroidism again favors the occurrence of rapid cycling. And also long-term aggressive use of antidepressant. We have been discussing that antidepressant, if a patient has bipolar depression, we avoid giving just antidepressant because there is a risk of switch to mania or hypomania. Let's discuss some of the other points which have not been asked in the question. So menopause, again, it is also associated with favoring rapid cycling. Temporal lobe dysrhythmias, temporal lobe seizure activities, again that can also lead to increase of risk of rapid cycling. Lastly, you can also remember substance abuse. So a patient having bipolar disorder abusing substance such as alcohol, minor tranquilizers, stimulants, caffeine, again they also have a risk of towards rapid cycling. So I've given you a list. Please make a note of this list, very important for rapid cycling. The question which was asked in the January 2024 FMG exam was, what is the treatment, what is the drug which is used in rapid cycling? So can you tell me which important drug we use for rapid cycling? So please remember, in the treatment, valproate. So valproate is found to be useful in rapid cycling. In fact, recently now more studies have shown that even lamotrigine is also showing good results with the rapid cycling. So you can also write down lamotrigine, and sometimes we see that patients with rapid cycling may require more hospitalization. So you can add on these points, since we have such topics are getting asked again and again. So rapid cycling is an important topic. Can anybody tell me rapid cycling? We can also use antipsychotics, lithium, those can also be used. Okay, they also have modest results. Now can anybody tell me, if you have to tell me rapid cycling is more common in bipolar 2 or bipolar 1? So again, one more point you can remember, that rapid cycling is, most rapid cyclers we see have bipolar 2 disorder than bipolar 1 disorder. So bipolar 2 we know that a person having depressive and hypomanic episode, and bipolar 1 is depressive and manic episode. So again, this one more point you can add on in your notes. So this was about the first question. I hope this is clear to everyone, right? Great, right. So please write down these points as well, may be useful in the upcoming exams as well. Now next question, again I think this one is more of a straightforward question. In fact, this question also was asked previously in the exam. So in fact, autism spectrum disorder is an important topic. We have been seeing questions on especially Rett syndrome. I'm sure we have discussed questions on Rett syndrome recently asked in the INI-CET exams. So tell me the answer, just see the options and tell me, were there any changes? So the question is, which of the following is not included in diagnosing autism spectrum disorder? So just look at the options. So abnormalities in social communication, these are seen. Abnormalities in socialization, yes, these are also seen. So there are two core features we have discussed. There is deficit in social communication, and there is repetitive restricted patterns of behaviors, interest, stereotypies are seen. So restriction of patterns of behavior, interest, very good. So I'm very happy. So I hope you are able to answer this question. So cognitive dysfunction is not a core feature, is not a symptom we take for diagnosing autism spectrum disorder. I hope this is clear to everyone. So we have talked about this. In fact, even in the videos, even in the LRRs, we have talked about this deficit in social communication and repetitive patterns of behavior. So please do revise autism spectrum disorders. So please revise autism, Rett syndrome, childhood disintegrative disorder, Asperger syndrome. Again, question, this topic has been asked. So please remember this topic, somewhere or the other they've been asking. So in fact, this is a similar repeat PYQ of AIMS. So this is the second question. I hope this one is clear. Everybody has marked this answer correctly, right? So let's discuss the third question. Again, an interesting question. So when we talk about the etiology of depression, we discuss one very important psychological theory. So first, see this question again. So from the again the recalls which I've got, the question is, which of the following is not a component of Beck cognitive theory? I hope this is the question. It is not Beck cognitive triad. Triad is something else, we know. So this is, which of the following is not a component of Beck cognitive theory? We know Beck cognitive theory is for depression. So whenever we have discussed this theory, we have talked about. So let's discuss again. We have talked about this in the main videos as well. So cognitive theory of depression was given by Aaron Beck. So basically what Aaron Beck suggested, that in patients who have depression, they develop cognitive distortions. So there are cognitive distortions which occur. So what are cognitive distortions? Basically, these are negative, inaccurate ways, patterns of thinking. So basically, these are automatic negative thoughts which develop in the individual. So let's try to understand. So normally, all of us have certain core beliefs. So through our childhood experiences, through our environment, we develop certain core beliefs. Over these core beliefs, we develop certain intermediate beliefs, certain rules, certain assumptions, and over this, we develop certain automatic thoughts. So, you'll observe, if you sit silently, you'll observe automatically thoughts are coming. So what Aaron Beck suggested, that patients who develop depression, there is problem in the development of these core beliefs, and these patients ultimately they develop these automatic thoughts are actually negative automatic thoughts. Okay. So this is basically what is happening in depression according to Aaron Beck. So can you now answer this question? Which of the following is not a component of Beck cognitive theory? So what is the answer here? So cognitive distortions occur. Automatic thoughts, yes, there are negative automatic thoughts. Dysfunctional beliefs, yes. So patient develop these maladaptive ways of thinking. So what is not part of Beck cognitive theory? So the answer is introjection. But what is introjection? Introjection in fact is a defense mechanism. Introjection in fact is a defense mechanism which occurs in depression. What is introjection? Introjection means internalizing a real or imagined object loss. So what happens in depression if there is a object loss, real or imagined object loss? The person internalizes the feelings of that object. So this is a defense mechanism of depression. So I hope this is clear to everyone. Right. So let's come to the next question. Again, please remember, cognitive triad of depression is something else. So patient, according to Aaron Beck, he only give this cognitive triad of depression. In this, according to him, person develops negative views about self. I am good for nothing. I am a bad person. I am worthless. So worthlessness, negative views about the environment. Nobody can help me. Helplessness, negative views about the future. There is no hope for the future, which is hopelessness. I hope this is clear to everyone, right? Now, let's come to this next question now. So this image, again in the LRR also we discussed that images especially related to sleep are important. So let's talk about this question. Which of the following sleep stage is represented in the image? I hope this is the question. I hope, cognitive triad was not there. I'm just explaining what is cognitive triad. So we've talked about Beck cognitive theory of depression. I hope this is clear, right? Right. So am I right? This question mark, this was asked. Please see. So they had given EEG, EMG and EOG, that is electroencephalogram, electromyogram and oculogram. So you have to tell right. So I hope this is clear, right. So let us just see all these options. In fact, we have discussed this even in the main videos in detail. I have talked about these important findings in different stages. Yes. So please see this. So here can you see EEG is fast, EMG muscle activity is also fast, and EOG the ocular activities are also fast. So what is this telling us? That the person is awake. Please see here. Now the next one which was asked, most of the students are saying this second column was asked. So here can you see again the EEG activity is fast, but can you appreciate the EMG activity is nearly very less, while still the EOG is again fast. So what is this? What is this stage? Anybody? So remember, rapid eye movement, REM is known as rapid eye movements where the EOG is fast, and we know in REM there is muscles are in a state of paralysis. So the EMG will show negligible activity. So I hope this is clear. This is what? This is REM. And can you tell me what is this appearance known as? We have talked about this. What is this appearance? So we know in REM, although we are sleeping, but our brain is showing beta and alpha waves. What is this appearance known as? This was again asked. This was again only this REM EEG image was asked once in the exam. So what is this known as? This is sawtooth appearance. This is sawtooth appearance. I hope this is clear to everyone. Let's discuss the last column. Here again, can you see the EOG is slow? The EOG is slow while EMG is again present. EMG is showing activities and EOG again is less. So there is slow activity on EEG, muscle activities are present but eye movements are slow. So we know NREM, non-rapid eye movement. So what is this stage? The last stage is NREM. Can anybody tell me what NREM stage this could be? Can you see slow waves? The frequency is slow, but again very high amplitude. What are these? These are delta waves. These are delta wave. This is N3. This is N3. I hope this is clear. We have talked about, even in the notes also, we have in detail discussed about these waves, these findings of EEG, EMG and EOG. So please remember this. This was the table which I also discussed in the LRR. So we know these. What are these? Again, let's briefly discuss them as well again, because images are important. You are seeing a lot of questions being asked. Okay. So NREM 3 and 4, now they are combined into N3. So remember this NREM 1, 2, 3, this is an older classification, now we know. So NREM, let's discuss that as well. NREM 1, 2, 3 and 4, this was older classification. Now NREM 1 is known as N1, NREM 2 is known as N2, 3 and 4 now they are known as N3. Okay, so let's discuss that as well. Okay, so what is the answer? The right answer here is REM. I hope this is clear. So let's take this opportunity to discuss some important points. So just let's revise this again. So can you tell me what are these findings on EEG in N2 we are getting? What are these findings in N2? Anybody? What are these sudden burst of activities? These are sleep spindles. These are sleep spindles. And what are these? Sharp positive and negative waves. Can you appreciate what are these? This is known as K complex. So please remember these are K complexes. Okay, so this is seen in N2, and this we have already discussed, this beta alpha wave sawtooth appearance. So this is seen in REM. So again important for the exams, upcoming exams. Okay, let's come to this again. Alcohol is one of their favorite topics. Now this time they've asked about Korsakoff psychosis. Okay, they've been asking a lot of questions recently on Wernicke's. So this was, please see the question and tell me, are the options the same options which were there in the exam? Just have a look and then we'll discuss. Again, we have talked about Wernicke's and Korsakoff. So you have to tell which of the following features are encountered in Korsakoff psychosis or Korsakoff syndrome. We know it is a neurocognitive disorder, alcohol induced neuro. Very good. Options are also the same, options A, B, C, D. Can you just see? Very good. So we'll be saying yes, it is same options. Neurocognitive disorder, very important, one of the star topics of exams. So please remember this, very important. Now tell me the answer here. I hope we have discussed this, we have talked about this table as well. So can you appreciate? We know Wernicke's, the mnemonic is GOA, global confusion of ophthalmoplegia ataxia. Korsakoff, which is a chronic sequelae. Amnesia, confabulation, both occur because of deficiency of vitamin B1, and thiamine is the treatment. Yes. So the right answer here is, again, we know ophthalmoplegia. We know ophthalmoplegia is seen where? It is seen in Wernicke's and encephalopathy. Amnesia, again, anterograde and retrograde both can be seen. Anterograde more than retrograde. Confabulation, again, what is confabulation? Filling of memory gaps with false stories. Again, this can occur in Korsakoff psychosis, and even peripheral neuropathies. Peripheral neuropathies can occur even without Korsakoff, and with Korsakoff also they can occur in patients with alcohol. So what is the right answer here? 1, 2 and 4. So these are seen. I hope this is clear to everyone. Just see this. I'm happy if you have marked the answer correctly. Very important. Can you see again and again the topics are getting repeated? So it's again a very important topic, Wernicke's and Korsakoff. So please remember this. We have also in fact discussed in LRR some of the important enzymes. This is more of a biochemistry question. So thiamine pyrophosphate occurring as a coenzyme in some of the enzymes. So remember ATPB. So alpha ketoglutarate dehydrogenase, trans ketolase, pyruvate dehydrogenase, branch chain keto acid dehydrogenase. I hope this is clear. Though it's not necessary, yes, they can occur, yes, but generally, yes, they can occur. Generally, we say yes, Wernicke's, Korsakoff syndrome can occur, but sometimes separately can occur. Okay, so Wernicke's, symptoms of Korsakoff can also present separately. So please remember this. I hope this is clear. Right. So let's come to the next question. Again, this was one question which I would say yes, again, but still we'll discuss this question. This you might have difficulty. So MH, mental health gap program by WHO, World Health Organization, included all of the following disorder. I'm sure by now you would know the answer. So this is one question that has come as a a relatively new question. So what is the answer? I'm sure by now you would know the answer. I hope these were the options only: OCD, depression, psychosis, and childhood mental disorder. Okay, let me know if there is any change in any of the options. So what is the right answer? Okay, what is the, tell me if there are any other options you can remember, let me know. I'll modify the options. Acha, schizophrenia was there. Okay, psychosis will remove, will keep schizophrenia. Okay, so schizophrenia was there. Okay, schizophrenia. Okay, it's a psychotic illness. Okay, so schizophrenia was there. Any other modification? Other options were fine. Okay, it was given as schizophrenia, right? So the answer here is yes, OCD is the answer here, right? So basically what is this MHGap intervention guide? It is basically mental health gap action program. It is a program by WHO basically for mental, neurological and substance use disorders in non-specialized health settings. So in fact, version 2.0 was released by WHO in 2016. The first version came in 2010. So basically it includes some of the important mental, neurological and substance use disorders. So these are the 7 important conditions. You can remember, since this question has been asked, and if you want to remember, you can remember it with the mnemonic DPS desk. So DPS desk, by this you can remember. So what is D? Depression. P for psychosis, including condition like schizophrenia. 1S you can remember, substance use disorder. Then desk 1D is dementia. So neurological conditions are also there. Then E, so dementia, epilepsy is there. Then S, self-harm or suicide, and last is child and adolescent mental and behavioral disorder. So these are the important disorders covered in MHGap. So I've given you this mnemonic. So since this question has been asked, so remember these are the 7 important conditions which are included under MHGap. I hope this is clear to everyone. Now this is one more of a pharma question, but I'm sure we have been discussing this one point, and by that point also we could have solved this question. Cannabidiol is not used for, now what is the answer here? So basically the cannabis plant such as cannabis sativa, it has cannabinoids. So some of the cannabinoids such as tetrahydro delta 9 THC hydrocannabinol, we know this is the psychoactive agent. This is the psychoactive agent in cannabis. Then another cannabinoid you can remember, cannabidiol, and cannabidiol is used for certain epilepsies. So it is used for Dravet syndrome, tuberous sclerosis complex, so seizures with tuberous sclerosis complex, and even Lennox-Gastaut syndrome. So I hope you are able to answer this question, because we also know, we have read this in psychiatry also, that for Rett syndrome there is one drug which has been approved. So can you tell me the name? Can you tell me the name of that drug? We have been discussing that drug again and again. So sometimes, you know, even if you were not very sure, we know for Rett syndrome there is one drug which has been approved. So what is that drug? Trofinetide. Okay, in fact this was asked in last year's INI-CET exam. So this time they have give it as which drug cannabinoid is not useful for. So cannabidiol is not useful for. Yes, I hope this is clear to everyone. Sometimes you have to answer questions like this. Now another, very good, very happy, yes, very happy you're answering it correctly, very good. So again, this question, as a similar question again has been asked, this again will overlap with even forensic medicine as well. So let's discuss this as well. So previously a similar question also was asked in INI-CET in 2022. So tell me, so these are basically related with paraphilias. These are related with paraphilias. Okay, tell me. So what is Freudism? What is Freudism? It is basically rubbing of the private parts of a non-consensual partner. Then what is eonism? This question was asked in 2022. So what is eonism? Is another name for, okay, I hope this is clear. What is eonism? It is another name for transvestism. Yes, wearing clothes of the opposite sex. Necrophilia, again, what is necrophilia? Necrophilia, as the name suggests, sexual intercourse with dead body. What is algolagnia? Again, if you know, what is the meaning of algo? Algo means pain. What is algolagnia? It is basically sexual gratification by pain. So basically this is something, you know, we have read about sadism, masochism. So this is another name. So you can remember this is another name for, so algolagnia, remember, is 3 option. It is 3. I hope this is clear to everyone. Yes. So algolagnia is basically sadomasochism. Okay, I hope this is clear. A very similar question if you look, so that is why we've been saying that PYQs are important, the topics are important. A very similar question was asked, and in that question they had talked about eonism as well. So we know eonism is wearing, you know, opposite gender clothes. Very good. I hope this is clear now. Even if you didn't know about algolagnia, I hope you're able to answer this question. So the answer is option A. I hope this is clear. Right. So we have discussed this as well. In fact, even in the notes, even in the PrepLadder video also, we've talked about this in detail. So we have talked about transvestism, also known as eonism. So remember this point. Now let's discuss this question. Again, a very interesting question. Now this is one question I am sure, you know, it is a tricky question. But even if we don't know about this, sometimes, you know, we have been discussing that when we look at the option, we may be able to solve the question. So let's see this question and let's try to answer this question. The question is, which of the following supportive therapy is not given? Now basically please understand, let's try to understand. I'll come to the options. So we'll also try to answer when we see the options. Let's first come to the psychoanalytic psychotherapy. So when we talk about therapies, one of the therapies is psychoanalytic psychotherapy, basically which you know, deals with, goes into the details of the psychoanalysis principle. So it uses psychoanalysis principles, you know, principles which we have discussed in Sigmund Freud, and there are two important types. One is expressive psychotherapy and the other is supportive psychotherapy. Now what is expressive psychotherapy? Expressive psychotherapy is more of insight oriented therapy. So basically we go into the depth of the reasoning. So we try to go as deep as possible into the causes. So this basically we use for people who are more motivated, who have well integrated ego, who have a capacity to introspect on their behavior, on their feelings, on, and also who have self-control. So generally expressive psychotherapy is more of a detailed therapy which we do in people who are motivated, who have an integrated, well integrated ego. They can introspect, they have self-control. Now generally when do we use supportive psychotherapy? But as the name suggests, supportive. So in supportive it is more of you know, relatively superficial type of therapy. We are just supporting, managing the symptoms. So supportive therapy is basically more of relationship oriented. It focuses on the external events. So here we are focusing more on external events rather than the intrapsychic, rather than the events occurring in the mind. And generally we use supportive therapy, means we use supportive therapy when we are not able to use more detailed therapies. So we are trying to just support the symptoms. So where insight oriented psychotherapy is contraindicated, is not possible, there we use a supportive psychotherapy. So here basically we try to relieve the symptoms of the patient by modifying his behavior, his environment. Okay, so basically we help in coping skills. So we help the patient in coping skills, we help the patient vent out, we help the patient adapt to the current circumstances, environment in his life. So let's try to understand, but please try to see the options here. So where will you do supportive, you know, therapy? So basically we'll do supportive therapy wherein we are not able to do a detailed therapy, more detailed therapies. You know, for example, in depression, in OCD, in anxiety disorders, we have discussed certain therapies, you know, which are very structured therapy which we use. Now let's try to understand where we will use supportive therapy and where we will not use. So a person who is severely ill and is not cooperative, some students said that it was mentioned that it is a acute or a temporary mental illness. So please see the options first, then I'll discuss the answer. So the option number A is when the person is severely ill, is not cooperative. Can I use a more detailed therapy here? Can I use more detailed therapy such as expressive psychotherapy or other therapies? Second, so we'll come to second in later on. Person with cognitive and functional deficit. Again, persons who are having cognitive deficits, you know, functional deficits. Can I use more detailed therapies in these patients? You know, therapies requiring more motivation and more participation by the patient may be difficult. Another is patient who is severely ill and has lost his ego function. There is ego problem. So again, I may not be able to use certain structured therapy. So here I would require supportive therapy. Person who is motivated and has control on frustration, isn't it? There I would prefer certain other therapies, more detailed therapies, more structured therapy. So you have to tell me where supportive therapy is not given. So I hope, of course we can use, but we would think of other more better therapies here. I hope the question is clear to everyone. I hope this is clear. I'll give you some of the important indications. So let us discuss some of the indications of supportive therapy. So individuals who are in acute crisis, there is temporary state of disorganization. They are not able to cope with the current life situation. For example, there is a divorce, there is loss of job, and there is an acute crisis. So there we can use, in crisis intervention, we can use supportive care. Okay, this is one indication. Second is patient with chronic severe pathology having a fragile and deficient ego function. Again, in those situations, I can use supportive care. Okay. Then next is patient with cognitive deficit, physical symptoms, again making them vulnerable, where insight oriented therapies are not much, useful, or we cannot use them. And lastly, who are psychologically unmotivated. So patient has just come because family members have put pressure. Again, those patients may not be able to participate in more detailed therapy. So there also I can use supportive therapy. I hope this is clear to everyone. So the right answer was, in fact, it is suggested that supportive therapy, these are not recommended as treatment of choice for a patient who is available and capable of more in-depth approaches. There I will go with more specific, more structured therapy. I hope this is clear to everyone. So these were some of the important questions I've tried to gather. Okay, let me know if there are other questions. There was one question on alcohol, but I hope this time, I think this time it was more towards medicine or surgery. I think, because most of the students said that patient had a binge drink episode 7 days back, and then there were certain symptoms. Withdrawal symptoms were not much mentioned. I hope that is clear to everyone. Again, just so this was a brief session for the recall question, just a take home message from my side. But again, the exam is over. Don't get, don't stress a lot. Let's, it's gone, it's over. Let's now, think ahead. Okay, it's, if it is, your exam went good, it is very good. If it did not went so good as you were expecting, it's okay. So let's take some learnings from the exam. What are the learnings? Better, you gave a real, exam. So there was a real exam experience. Time management, which is going to be very useful for the upcoming exams, NEET, PG, FMG exams, those are giving FMG also. So please remember, try to utilize this experience. See what things went right for you, what things didn't go well for you, and try to rectify those things. It's very important. And also, again, we have one very important exam. Let's focus on that NEET PG exam. Okay. Any other question, any other query you had, you can of course, put in the comment section below. You can also message us on the Facebook group. So this was about psychiatry discussion, and also we are having a champions exam for NEET PG as well as FMG. Again, you can give them as well to get an idea of the questions which are asked and get an experience of giving the exam. So thank you very much. Thank you very much. May God bless you all. Again, as always say, keep smiling, keep moving forward. Okay, and everything will be all well. Take one day at a time, one session of study at a time. Thank you very much. May God bless you all.